This is a case presentation for CDS 898 by Samantha Neal. This case presentation is based on a patient from Ephraim McDowell Regional Medical Center in Danville, Kentucky. The patient is a 44 to 55-year-old female. The patient lives at home with her husband and has a number of children and grandchildren. Some environmental factors that affect the patient are that she is disabled and she does not work. The patient was transferred to Ephraim McDowell Regional Medical Center from another outside facility due to COPD exacerbation and acute respiratory failure. The patient was intubated at the outside facility prior to her transfer to Ephraim McDowell. Additionally, the patient was mechanically ventilated at Ephraim McDowell for more than 5 days. The patient is around 5 foot 5 inches tall and weighs nearly 300 pounds. The patient has a medical history remarkable for COPD, MRSA, diabetes, tobacco use, and the patient is morbidly obese with a BMI of 49.5. The patient received a tracheostomy following 3 days of mechanical ventilation via intubation tube. The patient received an extra long cuffed trach. The patient has received several chest x-rays during her stay, indicating that she has pneumonia. The patient was afebrile during her stay with an O2 saturation average of 96% via nasal cannula and a white blood cell count range of 6.24 to 7.66. The patient has some chronic health issues including COPD, MRSA, diabetes, tobacco use, and morbid obesity. Currently, the patient's home medications include albuterol and metformin. Some physical limitations that the patient has is that she is disabled and morbidly obese, which affects her movement and ambulation abilities. Currently, there are no psychological factors affecting the patient. The husband, children, and grandchildren of the patient were not observed during her stay. The patient would, however, speak of her children and grandchildren and once indicated that she was nervous of her grandchildren seeing her with her tracheostomy because she was afraid that they would be scared and not want to visit her. Some additional cultural issues that the patient faces is that she lives in rural Kentucky in an area where there is not a medical facility nearby, so any sort of hospitalization or outpatient procedures required travel or an overnight stay. Speech therapy was consulted to evaluate the safety of the patient's PO intake, least restrictive diet, and voicing abilities after her tracheostomy. A FEES study was completed, and the patient was found to have reduced laryngeal elevation, reduced tongue-based retraction, and reduced oral bolus cohesion. The patient displayed penetration with thin and nectar-thick liquids and regular solids. The patient displayed aspiration with thin liquids. Patient presented with mild to moderate follicular and piriform residue. Diet recommendations included nectar-thick liquids and mechanical soft solids. The patient was unable to produce voicing with her extra long cuffed trach. Following the FEES study, the patient was diagnosed with oropharyngeal dysphagia. Due to the multiple and complex issues facing the patient, the main focus of treatment was diet tolerance and swallow function exercises. Additionally, the patient was not appropriate for speech production due to her inability to produce voicing until after her trach was changed. The production of long-term goals were not part of our care plan since the patient was seen in an acute care facility and was being transferred to a long-term rehab facility. However, her goals would have included toleration of thin liquids and regular solids, as well as vocal production with an uncuffed trach. The patient's short-term objectives included: patient will show no more than one overt sign of aspiration in 10 to 15 trials over 1 to 3 sessions. Patient will verbalize understanding of dysphagia education, and patient will complete oral lingual, laryngeal, and pharyngeal exercises in 20 out of 20 trials. Swallow function exercises were used to strengthen the oral motor muscles used for swallowing. The patient's therapy tasks included anterior to posterior lingual movement, where the patient was asked to raise her tongue tip and draw the tongue tip along the roof of her mouth. The Misako maneuver, where the patient was asked to place her tongue between her teeth and close her lips around her tongue. The patient would then produce a swallow with her tongue between her teeth. And finally, the green swab hold, where the patient was asked to place a swab on the posterior portion of the tongue and hold the swab between the tongue and the roof of the mouth for 4 to 5 seconds with light resistance placed on the swab. The patient was compliant to swallow function exercises. The patient would indicate that she practiced exercises independently, which was evident by the degree of her improvement. The only changes that were made to the patient's treatment plan were the number of repetitions of swallow function exercises due to her quick improvement. From her initial treatment session to her final treatment session, the patient improved with diet tolerance. In her initial treatment session, the patient produced one overt sign of aspiration with nectar-thick liquids, and in her final treatment session, the patient produced no overt signs of aspiration with nectar-thick liquids. Additionally, the patient showed improvement in swallow function exercises from her initial treatment session to her final treatment session. In the initial treatment session, the patient produced anterior to posterior lingual movement in 20 out of 20 sessions and was able to increase that to 30 out of 30 by the end of her treatment. She would produce a Masako maneuver in 16 out of 20 trials, and by the end of her treatment was able to produce it in 25 out of 25 trials. The patient additionally was able to increase her endurance for green swab hold from 10 out of 10 trials to 20 out of 20 trials. The patient was discharged from Ephraim McDowell and transferred to a swing bed before being transferred to Cardinal Hill. Speech therapy recommended a continuation of swallow function exercises, diet tolerance treatments, and voice production. Due to the complexity of the patient's medical problems, collaborative work with the patient's medical professionals allowed the patient to make greater improvements in the realm of voicing with her trach. Initially, the patient was fitted with an extra long cuff trach, which prevented her from producing voicing. After collaboration with the hospitalist, the general surgeon, and the SLP, the patient was able to change to an extra long, uncuffed trach, which allowed for some amount of voicing. Given the chance to work with this patient or a similar patient again, I would be sure to collaborate with the patient's medical providers to advocate for the patient's ability to produce voicing sooner. The patient went several days being unable to produce voicing following nearly a week of being sedated. The patient's overall morale and emotional status were affected by not being able to produce voicing. Once the patient's trach was changed, the patient's willingness to participate and overall quality of life improved.